So I'll move on to the topic that's given to me, which is on emergence and extubation. Should we have a plan? Well, my first slide, before I move on, I'll just tell you what I plan to discuss in the next 1 hour. We will just have a brief look about the steps involved and timing of emergence and extubation, what factors contributes to adverse events and what you should know, and complications of emergence, extubation, and recovery, what methods are available to optimize the conditions prior to emergence and extubation, and finally, the technique and planning a safe extubation for your patient. Again, I would like to acknowledge some of my colleagues who have really shared their experiences with us, because I've got some interesting cases. And also I acknowledge Google Images, from which I've actually taken most of the images for this presentation. So how many of you have experienced a situation like this, a scenario like this? As medical officers in anesthesia, I think we all have. I certainly have. And I believe that all of you have the same experience as I do. At intubation, you've got lots of people around you. Everyone's so keen to know whether you can get that tube in. Some even want to learn how to put that endotracheal tube in. And then here comes extubation. You're all alone. And I think that we've all felt, right? So there's no one here beside me. But this is not the only problem. This certainly is a problem, but this is not the only problem. So what next? Let's have a look at the problem of or what happens at emergence and extubation, because that is important to sort of highlight the magnitude of the problem. So what has been found and what's said in the literature is that emergence and extubation are times of increased risk in all anesthetics. And actually, more complications occur at extubation rather than at induction and intubation. And if I'm to give you some numbers and values, 3.8% of patients experience airway obstruction, either immediately following extubation or in the recovery area. And these NAP4, these are national audit projects which they conduct annually in the United Kingdom, and they find an interesting topic and they look into the causes, and after that they find recommendations for it. So this NAP4 was all about basically airway complications. And what they found out was that 1/3 of the major airway complications actually happened at emergence and recovery. So this is of noteworthy, because here itself tells us that there is a big problem and things can go horribly wrong if we are not prepared for it. Because it's understood that at intubation, it's more of a controlled sort of area, a controlled condition, right? It's all created for you. But what happens at tracheal extubation is a lot of attention is deviated, and the focus of the theatre staff is all scattered. They want to get ready for the next case. So therefore, they even forget the fact that the patient on the table has still not recovered from the anesthetic. So it's often an underestimated and neglected, I wouldn't say area, but given to me and shared by one of our colleagues. And this is a question which I would like to pose. What would you do? And do you anticipate a problem here? So here's a 74-year-old man who was diagnosed with a multinodular goiter for 50 years, and he was scheduled to undergo a total thyroidectomy. His background, he's a hypertensive, a diabetes, and a patient with dyslipidemia. He complained of on and off dyspnea, but he had no other pressure symptoms. His MET was less than 4, but the vital parameters were quite stable. Clinically and biochemically, he was euthyroid, and his vocal cords were normal on FOL. Ultrasound scan showed retrosternal extension, anterior tracheal compression with displayed carotid arteries, both carotids laterally. Intubation. It was a standard induction, grade 1 BWAT laryngoscopy, and a large goiter was removed. The question I'd like to pose to you is, would you extubate or do you not extubate? think a moment and what you would do. Well, it's all gone very smoothly despite it being a large thyroid. So the team decides to extubate. And this is what happens next. Patient is struggling with mild stridor. What do you do now? What's next? Any thoughts? Anyone wants to unmute and answer? I know it's a large crowd to actually ask questions, but this is just a thought-provoking thing. Okay, so what happened is basically, obviously, you need to re-intubate. They went into a re-intubation, and what they found very interesting, they did not really anticipate, but it was a difficult intubation. The endotracheal tube was obstructed beyond the vocal cords. The patient was transferred to the intensive care unit and was extubated subsequently. However, there were episodes of desaturation and extubation failure. So what resulted next was also tracheostomy. And FOL done showed that there was bilateral vocal cord edema and there was no tracheal narrowing. At this point, when the patient fails to get extubated, the surgical colleagues then informs the anesthetist that they did find certain things which obviously was not divulged to them. There had been a potential space which was noted around the trachea, and the lateral and the anterior tracheal walls were weak. So what lessons have you learned from this? Anyone? Anyone wants to say anything? What lessons have you learned from this?
Not to trust surgeon.
Well, yes, to some extent, but I will put it in a more milder form, communication. So there was a huge lapse in communication between the teams. So if it was revealed, then things might have been different. And this is extremely important. But I think from an anesthetist perspective as well, maybe it is all right, even if they don't talk to you or if they don't tell you, you can always ask them. Not that I'm saying that you will always get like 100% answer, but communication has been the biggest lapse here for this failure. And to plan your extubation, because we knew at the beginning this was quite a large goiter with a lot of compressive symptoms, even though he was not symptomatic. The ultrasound scan showed that the carotids were displayed, and it was a long-standing goiter. So obviously, we do expect tracheomalacia, and this is exactly what had actually happened, right? So it wasn't really planned to some extent, and planning your re-intubation is equally important, because if there is a collapse, you know it's going to be difficult, right? And it did prove to be difficult. So these are some of the things which should come to your mind, because it's very important for us to think of these aspects when we have a patient in front of us. So a little bit of theory about emergence extubation, the steps and timing. So we know that when we talk about emergence, it's a state of, a transitional zone, a gradual transition from a patient who is unconscious, which obviously. And I've just showed you these stages of anesthesia by Giddle. And the reason why I have shown this is the reverse of this is what actually happens at emergence. We know stage 1 is a state of analgesia or disorientation, where the patient is conscious, but there is a decrease in the level of consciousness. Then there's a phase 2, which is the phase of excitement or delirium, where there is a bit of disinhibition and delirium. And you will find that finally the patient goes into a state of surgical anesthesia, which is stage 3, and finally the stage of overdose. But it is the reverse which actually happens when the patient comes out of the anesthetic, what we refer to as emergence. So this is the time where there's a return of cortical functions, there is protective reflexes coming back, and then there is a respiratory drive and a lot of physiological changes. And most problems, because of these changes, is related to obstruction of the airway and also because of exaggerated airway reflexes. Now, there is a term called delayed emergence, which is quite individualized. It varies from patient to patient, right? Some emerge fast, some takes longer. But patient fails to maintaining an adequate level of consciousness for, say, 30 to 60 minutes, which is almost about an hour after general anesthetic, is by definition called delayed emergence, right? And that is despite discontinuation of our anesthetic agents. And this requires investigation. Now, it's important for us to have a little bit of theoretical knowledge as to what could be the causes of delayed emergence, which is actually multifactorial. And I've just displayed this in this table. There could be pharmacological as well as non-pharmacological causes. So we all know drug-induced. Residual paralysis can actually impair upper airway tone and also the respiratory muscle power, leading to hypoxia and hypercarbia. And ideally, we should be using neuromuscular monitoring if we use these drugs, especially in patients who have prolonged surgery or has, some form of organ impairment. It's very important that we use the neuromuscular monitoring devices whenever it's available to us. We also know that intra use of opioids and benzodiazepines are other causes of delayed emergence. And calculation errors, especially for obese patients, if you use actual body weight or the total body weight for most of the drugs, like opioids or maybe drugs like rocuronium or infusions of propofol, we might be actually ending up with a patient who has a delayed emergence. And patients with organ failure, which can be liver, which can be kidney, which can be pharmacological causes, any electrolyte, metabolic and electrolyte disturbance. Or it can be things like intra strokes a patient gets, especially if they have a background of long-term diabetes, hypertension, past history of peripheral vascular disease, or certain surgeries like head and neck, vascular, and cardiac surgeries, and also any other cardiac cause like prolonged hypotension. So any of these factors, there could be many more, which can actually cause a delay in emergence. Now, emergence delirium, on the other hand, is slightly different because here you will either have a patient who is hyperactive, which is what we notice most of the time, but it can also be hypoactive. The hypoactive is actually a continuum of the delayed emergence. Now, emergence excitement and agitation is seen more in children. Most of the time, our patients wake up, they're able to maintain their respiration, they can breathe spontaneously. But then you also have a subset of patients who become very excitable, they get disinhibited, confused, restless, so they're pretty much distressed. And these defensive movements can actually not only harm the patient, but can also harm the staff. And this is actually a problem. So reassurance, reorientation, and removal of the noxious stimulus. So sometimes it might be the airway which is in situ, which is really causing that, the distress or basically that restlessness or delirium. And you can think of removing it if you think the time is right. But if it does persist, you need to consider other causes, which can be any of these. Pain is one of the commonest causes. Even a patient with a full bladder where the surgery has been taking a long time, we've not catheterized, we've given fluids. Think of full bladder, residual drug effects, and also drug overdose or drug toxicities. So these are some of the problems that we actually would encounter during emergence, either a delayed emergence or delirium at emergence. Some of the complications which we might encounter at emergence and extubation. So with incidents, some of the very common ones we all know is somebody coughing and bucking on the airway device, going into laryngospasm and desaturating, breath holding. We've all seen this. Airway obstruction, which I will come to, which can be due to a number of causes, or basically hemodynamic instability, which can be hypertension, tachycardia, and so on. What they have termed as common in terms of incidents, which is more than 1 in 1,000 to less than 1 in 10, is inadequate reversal, apnea, hypoventilation, and residual neuromuscular blockade. Uncommon ones, fortunately, post-obstructive pulmonary edema, bronchospasm, vomiting, and aspiration. and rare dental damage. And these things can happen, and I'm sure some of you have experienced it, will happen during emergence and extubation. Now, what's leading to these complications? We know one of the biggest causes is airway irritation, and that actually results in all these things which we listed before. Reduced level of consciousness, where the reflexes are obtunded. There can be breath holding, airway obstruction, apnea, hyperventilation, so all those things which we said, the main cause is a reduced level of consciousness. Of course, it could be any cardiovascular change, and that is why you get arrhythmias, what we termed as hemodynamic instability, which can even raise intracranial and intraocular pressures, which can be quite detrimental in patients who undergo neurosurgery and ophthalmic surgeries, which can even precipitate myocardial ischemia. Trauma, and then drug effects. So these are the causes which leads to the previous complications, which I mentioned in the previous slide. Moving on. Now, this is a very, very interesting case, which actually happened not so long ago. Again, I acknowledge my colleague who actually gave this to us. There's a lot to learn from this case. Now, my question to you is, what would you do? And do you anticipate a problem? Think a moment. This is a 52-year-old man who's coming with a background of diabetes. He had no records, and his compliance seemed poor. He presented with a painful facial and neck swelling for 1 week, which he has been getting oral antibiotics from outside. He comes in with bilateral neck and facial edema. There was no difficulty in breathing. There was no hoarseness in voice. On-air saturation was about 99%. He had stable vital parameters. And an ultrasound scan reveals Ludwig's angina. So he's got a right parapharyngeal abscess, and the size is 2 into about 1.2 centimeter collection. That's about the size, and that was a collection. He's got raised inflammatory markers, both C-reactive proteins and the white blood cell count. They decide to give a course of antibiotics. They give painkillers because he did have a certain degree of pain. Due to his poor compliance in diabetes, they start him on insulin. Day 3 post-admission, the surgeon decides to do an IND under general anesthesia, and the team anticipates a difficult airway. So they go for a gas induction. They're prepared with their difficult airway trolley, but they found no difficulty in ventilation. There was no difficulty in intubation, and it was quite a successful IND. Pus was drained and drains applied. He, in fact, has a very safe extubation, and he's sent to the ward. They monitor him, antibiotics are continued. Everything is uneventful up until day 6 post-admission, where they notice that his swelling is now increasing in size, and saturation still remains 99% on room air. He does not require any oxygen. He's got no features of airway obstruction. So they decide that an IND is re-required, and this obviously requires a general anesthetic. Again, the team prepares for a difficult airway. And as anticipated, it becomes a difficult bag mask ventilation. They do a gas induction at this point as well, but they had been struggling in the during the second surgery with ventilation. However, they managed to intubate this patient, but this time with a smaller size endotracheal tube, because there is significant airway edema. So they managed to put a 6.5 millimeter endotracheal tube in this patient. The anesthetic team very correctly decides not to extubate this patient after an IND because they struggled with a difficult ventilation as well as a difficult intubation. So they take the patient to the intensive care unit with endotracheal tube in and decides to ventilate until the airway edema settles. So he gets the same treatment, antibiotics and insulin. 2 days later, they do the cuff leak test. Now, this cuff leak test is where they actually, as you can see in this diagram, they deflate the cuff and they see whether there is an air leak, as the name itself implies. I'll come to that a little later in the next couple of slides. and he passes the cough leak test. But so he manages to get a safe extubation done, but he stays one extra day in the ICU. It's quite stable. He's able to maintain his airway, and again, his saturation on room air is 99%. They do a CT, and these are the CECT findings. He's now developed an infective pseudoaneurysm on the aortic arch, involving the posterior and the right lateral walls between the origin of the left subclavian and the brachiocephalic trunk. There's a high dense collection which had been seen in the superior mediastinum adjacent to the pseudoaneurysm, which appears to be extending into multiple neck spaces. So this is problematic now. The team refers this patient to the cardiothoracic as well as to the vascular surgeon. But they say that there is no intervention or interventions possible for this patient. The ENT team decides to explore the deep neck tissues, and they drain more pus, and also they remove blood clots. And that comes a lot from the left sternocleidomastoid muscle. They send the pus for cultures, and they find that there's a large defect in the posterior oropharyngeal space, which is extending almost up to the prevertebral fascia, filled with blood clots. So this is definitely not something you would like to see in any patient. Post of day 4, after the second IND, he suddenly desaturates while he's sitting on that ICU bed. He goes into a sudden cardiac arrest, and the team commences CPR as per the standard protocol. They now get into a situation where they cannot intubate, they cannot oxygenate. And there's loads and loads of blood clots obstructing the airway. They resort to their emergency plan. Now, this is a very interesting thing, and I think we really need to appreciate this medical officer. Unfortunately, I did not get his consent to say who he is, but he becomes, the hero of the day. Basically, he does the emergency surgical tracheostomy. He's a medical officer in anesthesia, and he does that in the ICU with all that, problem of bleeding, blood clots, obstructed airway, and in a panic mode. He does an excellent job, and he manages to pass a tracheostomy, a tube 7 millimeters. And this surgical tracheostomy actually stays till the end. Sadly, this is the patient. These are actual pictures. And so this is how it was at the end. And there was lots and lots of blood clots, lots of bleeding. And this was a surgical tracheostomy done by the medical officer who was competent enough to do it at that point. They managed to, now obviously they've secured the airway, they managed to oxygenate. Ventilator, again, goes back on antibiotics, microbiology input is obtained. They re-refer actually to the cardiothoracic, vascular, including interventional radiologists to ask if there's anything that they can do. But it's just a matter of time, day after this whole episode, he actually has a massive bleed. They activate the massive transfusion protocol, but they realize that after giving the 2 packs, it was absolutely futile. And he has a massive hemorrhage, and he succumbs. I would like to get your thoughts on this. It was a bit of a long story, but what lessons have you learned? Do you think it was managed well or not so well in terms of anesthetics? It was unfortunate that he could, he did not make it, but that was because of the underlying pathology. But in terms of airway, how did you think this went for the team? Any thoughts, any ideas? I would really like to hear from one of the anesthetists. Okay, you might be having your thoughts. Anyone? Yes, anyone want to say anything?
Hello, madam. After the second IND, was he extubated?
No, they decide to, yes, so he was not immediately. He was kept in the ICU. And it was 2 days later when he passed the cough leak test that he was extubated.
So after the all imaging studies explaining all the horrible things on the airway, related to airway, would have been a good idea that he ended up in a elective tracheostomy.
Yeah, I do agree on that. Any other thoughts? But they actually do manage to do that in an emergency situation. So that was also something I thought which was really commendable for a medical officer to do that.
Yeah. Yes, ma'am.
Yeah, so I felt, I do agree with you totally, but I also felt that actually from the inception, from the beginning, this patient got admitted, they actually did plan and prepare because they were always ready for a difficult airway. So they knew even the first and the second time that, they would be expecting that. And especially following the second post-extubation, they actually decided to keep him ventilated. They performed the second extubation once, obviously, the patient passed the cuff leak test and his parameters were stable. But I do agree on the fact that the CEC finding was not great. And post-extubation, well, they did actually have a higher level of care and they did follow the DAS guidelines. And I think one of the key things is the skill which the medical officer actually performed at that point, which would have, well, sadly didn't save this man's life, but it can definitely save someone's life. So knowing how to do a tracheostomy, I mean, this was a surgical tracheostomy, but, in a situation like this, to be able to do that was something I thought was really commendable. So I thought this was a really nice take-home message in that sense. But I do agree on the fact that maybe they could have sort of, kept him like that. But I think it was a bit beyond repair because there was nothing that could be done for this patient's underlying problem. So coming to upper airway obstruction, I'm just going to touch a few things on theory. During emergence, we know that lots of things can happen, like foreign body obstruction, which can be blood clots, aspirated contents, thick sputum, or retained throat pack. There could be intubated-related injuries like upper airway edema and airway trauma. There can be causes like vocal cord disorders like laryngospasm and vocal cord palsy. And also external compression, which is not uncommon, anterior neck hematoma, especially after thyroids. How do you avoid upper airway obstruction? It's very important to do suctioning of the upper airway thoroughly prior to extubation and ideally under direct vision. Ensure hemostasis is achieved, especially with airway surgery. Place and remove the throat packs with all theatre staff noting the time, especially wherever it's being used. And airway edema, if you suspect, there is a role for prophylactic use of steroids, especially in head and neck or max-vax surgeries, or maybe even after lengthy surgeries in the Trendelenburg position. Now, this thing about the cuff leak test, which was actually done on that patient, it is something which they say that you should trial to aid in planning the time and place for extubation. So what is this cuff leak test? When do we say that the cuff leak test, a patient has passed the cuff leak test? So this is really the difference between the tidal volumes, the exhale tidal volumes, before and after an endotracheal tube is deflated. The cuff is to be about 10 to 25 mils. The difference between the exhale and the tidal volumes before and after tube cuff deflation, then it's quite safe to actually extubate the patient. Let me just put this case across to you. This is from the ASA, the American Society of Anesthetists, a case report of a uneventful surgery. They perform nasal endoscopy at the end of the procedure and what they not to resect. But of course, again, it does not get communicated to the anesthetist. And now at the end of surgery, the patient is responding to command. So the patient gets extubated. And what happens next? He soon becomes obstructed. So the anesthetist vigorously does suctioning and try to remove, blood out of the airway, but there's more and more blood coming out. They insert a nasopharyngeal airway because now you find that the patient goes into laryngospasm and his saturation drops to 58%. And what they do is they give 3 minutes of CPAP, the laryngospasm improves, patient becomes stable, and they transfer the patient to the post-anesthesia care unit. 1 hour later in the PACU, he becomes tachypnic and his saturations drop further to 85%. What happens next is he develops negative pressure pulmonary edema. They do give 24 hours of supportive management, and fortunately, he manages to the pulmonary edema resolves, and he manages to get discharged from hospital the following day. So this is a bit of an uneventful discharge. But what lessons have you learned from this case? Anyone? Again, it's a communication breakdown between the surgeon and the anesthetist. If the surgeon did communicate to the anesthetist about the hypoplastic adenoids, the approach to extubation might have been quite different, and it would have been done with great care and caution, and maybe a gentle wake up. And I think the time period, because there was a 3-minute period of giving CPAP when his saturation dropped to 58%. So there should be a low threshold to deepen and reparalyze and avoid prolonged periods of hypoxia when a patient develops laryngospasm. So they felt that it was a bit too long just to give CPAP only, but they could have actually resorted to a few other interventions to actually break this laryngospasm. And it was unclear because the case itself, it says that it was very unclear from this case whether they actually used propofol and succinylcholine, because that was not really mentioned, to break the laryngospasm. Because the longer you keep, the longer the patient is going to become hypoxic. And treating laryngospasm aggressively would have been much better than somebody developing a post-obstructive negative pressure pulmonary edema. So this happened because the laryngospasm took some time to resolve, and probably the management could have been a little different. So these were some of the lessons that came up from that particular case scenario. So laryngospasm, again, a lot of us would have experienced it. A lot of you would have managed it. So what you need to do is you need to clear the upper airway. And it's important that you avoid extubation in a transitioning plane of anesthesia. The surgery should be over and the patient should have recovered and should be fully optimized, and rather than doing it in a transitioning plane. And the Larson's maneuver, this is a maneuver which they actually describe to break the laryngospasm. They don't really know the exact theory behind it as to how it does it, but it is basically placing very firm digital pressure, which is a very painful stimulus, and it's anterior pressure between the mastoid process and the mandible. So we all have a bit there, which is called the laryngospasm notch. You apply firm pressure. At the same time, you do a jaw thrust. And what they think is because of this firm pressure that is applied in the laryngospasm notch, there is a lot of stimulation of a lot of nerves, the facial, the glossopharyngeal, and also a lot of mandibular pressure, which will actually stimulate even the vagus. And as a result, will break that laryngospasm. So the vocal fold and the cords relaxes by applying this firm digital pressure. And it's a very painful stimulus. It's not just the jaw thrust, but it's firm pressure just behind the pinna of the ear. So this maneuver has been quite useful in breaking laryngospasm, especially in pediatrics, and it's used in adults as well. But of course, continuous positive airway pressure with 100% oxygen, and deepening of anesthesia with propofol, and lastly, paralyzing them with intravenous succinylcholine is another option. So what we've said is you can use about 20% of the induction dose of propofol. And if you want to give succinylcholine, it can be anything between 0.1 to about 0.5 milligram per kilogram. Very rarely would you need large doses just to break the laryngospasm. So act fast, because that would be quite helpful. Vocal cord palsy, or basically tracheal sort of compression because of post-goiter surgery or after thyroidectomies would also require some assessment with fiber optic bronchoscopes. Airway compression from neck hematoma, again, is not an unknown complication. And what's been recommended is instantly to remove the stitches in the skin and the fascial layers and to remove the clips so that you can evacuate the hematoma, and the patient has to be taken immediately to the theater by informing the surgeons as well as the theater staff. So it should be, the expanding hematoma should be removed as early as possible. And this infographic I actually got from anesthesia, which has actually, it's given a mnemonic called DSATs. So when you believe that, there is a hematoma following thyroidectomy and the patient is desaturating, they say to think of, things like difficulty swallowing, think of a cause, whether this could be a hematoma, use early warning scores. If the patient starts developing a swelling or the patient becomes extremely anxious, patient is tachypneic, finding it difficult to breathe, and patient develops stridor. You closely monitor for DSATs, and this may actually tell you that this is a problem. There's a problem here and probably a hematoma developing after thyroid surgery, and you need to take the patient immediately for evacuation to theater. This is a story which came from the National Audit Project, which is again quite interesting. This is of an ASA2 patient with a BMI of more than 35. The patient undergoes an elective nasal surgery. Patient also has obstructive sleep apnea, is a smoker, and has obviously features of OSA. The pre-op assessment was recorded as normal, and a staff-grade anesthetist performs an intubation. It has been a grade 2 view using an 8 millimeter endotracheal tube with the aid of a bougie. Initially, he had tried using a size 9 because obviously this patient was quite large, but he found that to be too large. The operation becomes, as always, goes very uneventfully, and the patient was extubated in the sitting position in the operating theater. Laryngospasm develops and the patient desaturates quickly, and they find now that they're unable to bag mask ventilate. Here, propofol and succinylcholine was given, but an appropriate size tracheal tube was not available in the second round. And it took about 5 minutes actually to obtain the endotracheal tube, the correct size tracheal tube to intubate the patient. By this time, the oxygen saturation has gone down to 60%, and it remains like that for 10 minutes. And the patient develops bradycardia secondary to hypoxia, which responds to atropine. And a consultant comes in by this time and re-intubates. And this time, what was a grade 2 view is a grade 3 view and requires 3 attempts by the consultant himself. And pulmonary edema was noted, and the patient gets admitted to ICU. But promisingly, the patient makes a very full recovery and it gets discharged. But it's a pretty scary situation. So what has gone wrong here? The patient develops post-obstructive pulmonary edema. And why was that? Because the patient developed laryngospasm, or it may be because of any airway device or occlusion from biting. What happens here is there is a large negative intrathoracic pressure which gets generated by a forceful inspiration against an obstructed airway, because the airway is obstructed now, and there is a forceful generation there's a huge force generated. Negative intrathoracic pressure will now draw the fluid down a pressure gradient, which is exactly what happens in pulmonary edema, and from the pulmonary capillaries into the alveoli. And finally, the patient obviously will develop respiratory distress, and like usual pulmonary edema, they have pink frothy sputum, and patient will desaturate. So treatment, again, is oxygen, oxygen, and oxygen, and CPAP. Plus or minus, you might need to give intermittent positive pressure ventilation. But the role of diuretics in what's called POPO, or post-obstructive pulmonary edema, is very limited, right? And so it's quite a supportive management. And this is probably what actually happened to that patient. So what are the problems that, can happen? What can go wrong? There can be hypoventilation due to residual effects, which can actually cause airway obstruction. So what must you do? You must consider oxygen and adequate pain relief. Hopefully, you can use all the blocks now that is available, and go for opioid sparing, because these are some of the other problems that you might encounter during extubation and emergence. You can have patients who will aspirate. So clear the airway at emergence and ensure the patient's protective reflexes are back before you extubate. Patient can have unstable hemodynamics due to increased sympathetic tone. So there are various drugs which can upturn the extubation response, just like your intubation response. Go for a deep extubation. We'll come to that in the last couple of slides. And you can also go for an advanced technique, like replacing the endotracheal tube with a supraglottic airway device, which is called the Bailey's maneuver. So these are some of the other problems, in addition to what we discussed in terms of upper airway obstruction, laryngospasm, post-obstructive pulmonary edema. These are some of the other problems which you will encounter during emergence and extubation. So keep this all at the back of your mind when you have your patient in front of you. So how do we go about doing it? And this is where we have got a guideline, because the rate of extubation failure is about 0.1 to about 0.45%, according to the literature. And by definition, an extubation failure is defined as when you need to re-intubate or reinstitute ventilatory support within 24 to 72 hours of planned extubation. And following this 2011 NAP4, in 2012, the Difficult Airway Society came out with some algorithms. And it's all to do with 4 Ps. You need to plan your extubation. You need to be prepared for your extubation. And then you perform your extubation depending upon how you have planned and prepared. And it doesn't stop there. There should be very good handover and post-extubation care. So let's have a quick look at this. So this is the algorithm that has come out. So they came out with 3 algorithms, what is called a basic algorithm. And they also looked at the risk factors, and depending upon the risk factors, there are 2 other algorithms for the low risk category and the at risk category. So if you look at the basic algorithm, the first step is planning. And that is, you need to plan depending on your patient. So you've got to ask the questions about your patient. So if you remember in our previous slides, we spoke about what are the causes and the complications that can happen and what kind of patients are at high risk. You must always ask the question, does my patient have an airway problem? Would my patient be at a risk of airway-related problems? Or does my patient have a general risk factor? So airway risk factors are all that has been which has been stated here, from restricted airway movements, obesity, risk of aspiration, known difficult airway, or any systemic problem. And then you prepare accordingly. So in order to prepare, you've got to make certain things conducive in terms of the environment as well as the patient. So optimize the patient's cardiovascular, respiratory, metabolic, and neuromuscular function. And so ask the question, is this the correct location? Do I have the adequate skill and help and assistance? Do I have the necessary monitoring and equipment? Depending on that, you're obviously going to risk stratify your patient to either a low risk or an at-risk patient. So obviously a low risk patient is a patient who doesn't have any of those risk factors, who's fasting, and there's no general risk factors, or he has a very uncomplicated airway. You follow the low risk algorithm, which we will come to in the next slide. But if you think your patient is at risk and you're not sure about the ability to oxygenate, or you're not very sure about reintubation, patient is having lots of general and airway related issues, then you follow the at-risk algorithm. Once you perform the extubation, depending upon the risk, you need to actually go for post-extubation care. And that is not just sending the patient to the post-anesthesia care unit or to the recovery area, as you may call. You need to do a safe transfer. Communication plays a big role, because you saw what happened in some of the cases which we discussed, a huge communication lapse. You need to make sure that the patient gets oxygen, adequate observation and monitoring, and also make sure that staffing is available, there's equipment, the documentation happens, and give them adequate pain relief. So to plan, you need to know your patient. So what should you know about your patient? You need to know about patient factors. These are some of the things which can lead to complications at extubation. Does he have a cardiopulmonary, respiratory problem, morbidly obese, obstructive sleep apnea, GORD, smoking, all these problems that you may come up with? And anesthetic factors like, was it difficult to face mask ventilate, or did they use double lumen tubes, or was it difficult intubation, multiple attempts? So ask these questions and have your plan would be based on the fact whether the patient has any of these problems or there are any anesthetic factors. Once you plan, you need to get prepared. So how do you prepare? Again, you can see that you will ask or you will look for, if you go by A, B, C, D, E, you need to ensure that the airway is patent and the patient is able to protect the airway. Consider inserting a bite block if you think it's required. Remember your throat packs if you have inserted it, because that needs to be removed. Look at the adequacy of breathing, ventilation, give 100% oxygen. Circulation, is it stable? Make sure that the vital parameters are all stable there. Look at the drugs. Check whether you reversed adequately and ensure whether the patient has been given adequate analgesics. Maintain the environment, so the patient should not be hypothermic. You should have all your airway equipment ready. You should have your personnel ready. Positioning, because we do advocate the semi-recumbent upright position for extubation, especially in obese, which can improve their respiratory mechanics. And ask the question, is this the correct place for me to extubate? Because if it is not, it's better to take the patient to ICU with endotracheal tube, or you may want extra personnel. Like in the previous case, like one of you said, should you plan an elective tracheostomy? And also the human factors. So this is where you're getting your set, getting ready, or you're preparing yourself for the extubation. Then you perform. So basically, this is the algorithm where you're looking at whether it's a high risk or what we call at risk or a low risk, the same basic algorithm which I actually showed you earlier. And depending on this, you will perform your extubation. So this is from the Difficult Airway Society, the low risk algorithm. So the planning, again, the same thing. The low risk of extubation, so you prepare accordingly. You must optimize patient factors and all other factors. So that is basically your location, your health, your monitoring, and your equipment. What you need to select here is basically, am I going for a deep extubation or an awake extubation? Because certain surgeries like intracranial and ophthalmic surgeries, they would prefer deep extubation where you don't want a lot of coughing, bucking, straining, where it could increase the intracranial pressures and the intraocular pressures. So are you going for that? But in order to do that, you've got to be very experienced, or you need to have experienced health, and to be very vigilant when you do this, because you should be able to maintain the airway if you go for a deep extubation. If you're going for an awake extubation, which is what most of us would do in most situations, then you need to perform the awake extubation as stated here. Pre-oxygenate with 100% oxygen. Suck out for any secretions, preferably under direct vision. Insert a bite block if you think it's required. Position the patient in the most appropriate position which you would think is ideal for the patient. Semi-recumbent is fine. And antagonize the neuromuscular blockade. Establish regular breathing. Ensure that the patient adequately. One of the key things here is minimizing head and neck movements, because it's interesting. There was a lot of literature which came out saying that when you allow the patient's head and neck to move, they have found that there had been more complications at extubation and emergence, because that's probably irritating their trachea if they're like sort of partially awake. So you should try and avoid or minimize head and neck movements. Wait until the patient is awake. So this is an awake extubation, right? So the patient's opening the eyes and responds to your command and applying this positive pressure. What they say is that applying positive pressure at the time you deflate the block can expel some of the secretions and can actually, it's used as a recruitment maneuver where they can actually prevent atelectasis. But again, not a lot of hard evidence, but this is something that you can try. And of course, you need to give them oxygen and ensure that the patient can maintain airway adequately. So I read that because it's something which most of us do all the time, but these steps have to be remembered at all times. And then, of course, your post-extubation care. A safe transfer, a safe handover, clearly communicated, and ensuring that you've got everything on board. So this is the DAS guidelines for the low risk. And these are the same steps, more of an infographic of what I said, where you deliver oxygen, you suck out the secretions, inserting a bite block, positioning the patient right, reversing your neuromuscular blocking drugs, establishing regular breathing, avoiding a lot of head and neck movements, ensuring they respond to command, and then you apply positive pressure and then deflate and remove. And make sure that you give oxygen and you observe the patient. So these are the same key steps in low risk, where this infographic is quite self-explanatory. This is for the at-risk group. And again, it's plan, prepare, perform, and post-extubation. So planning, again, look at your general risk factors and ask the question, is my patient at risk? You then prepare and you optimize the patient factors as well as the other factors, just like in the previous algorithm. Here, the key question is not whether you're going to extubate deep or awake. Here, the key question is it safe to remove the tube? So you saw in some of our scenarios which we discussed, in some instances it was a yes, and some instances it was a no. So yes, then what would you do? Are you going for an awake extubation, or are you going to use an advanced technique? So there are only 3 advanced techniques which they have actually highlighted here. You can do a laryngeal mask exchange. So basically you exchange the endotracheal tube to a laryngeal mask airway, which is known as the Bailey's maneuver. That is one technique, so that there's a smooth extubation. Or we could use a remifentanil infusion. Sometimes we may be using remifentanil for the surgery, and we can actually continue it in the up until emergence and extubation. The doses are quite varied. It's not a huge dose, but you have to make sure that the patient does not go into a respiratory depression. So the doses recommended vary from about 0.04 to about 0.2 mics per kilogram per minute. Or the third advanced technique is where you put an airway exchange catheter. So this airway exchange catheter is somewhat like a bougie, but it's a very thin, flimsy catheter, which the patients are able to tolerate. You keep it so that if it's required, we can railroad another ET tube should be required to re-intubate the patient. So there are markings on these catheters, so we don't really, sort of insert it too deep. What they say is in an adult, you should not go beyond 25 centimeters. But since they're very thin and flimsy, they're able to tolerate this without any sedation. So that is if you are thinking you're quite safe to remove the tube. But of course, if you think it's not safe to remove the tube, you need to postpone extubation. And this is when you might want to take your patient to the ICU or recover in the HDU, or you go for a tracheostomy, which is done electively. And again, the post-extubation follows the same as before. Safe transfer and ensuring everything else is in order. So this algorithm, I mean, these two really, the at-risk and the high-risk, is actually quite useful when you have your patient in front of you.